Dear colleagues and students, this is Hani Arif, Professor of Neurology and the Director of this Ain Shams Neuro Academy program. It's the 16th wave of this program. You know, in the era of COVID and with social distancing, and of course, so we have to keep the education virtual. We hope that it's in the coming few months and weeks it will return back to physically fully, but still we have to do it virtually most of the time. So it's our pleasure in this wave today to have two of the most eminent speakers in the field of multiple sclerosis. We are having with us Professor Martin Touré from Spain and Professor Martina Absenta from USA. This session will be moderated by Professor Dr. Magd Zakaria. Of course, everybody knows him. He's a well-known figure in the MS field and the head of the MS Society in Egypt, and by me. So I urge everybody who will want to ask questions just to put the questions in the Q&A chat box, and we will answer the questions after the two presentations. I will let my colleague Professor Magd present Professor.
Thank you very much, Professor Hani, for this introduction. And of course, it is my honor and my pleasure to introduce not only one of the eminent MS figures all over the world, but a very dear friend. And we miss her all in Egypt here. We always enjoyed her company. So hopefully, as Dr. Hani said, that we will be able to host her in Egypt soon. Professor Martin Touré, of course, is a professor of neurology, the senior consultant, clinical coordinator of the neuroimmunology department of the MS Center of Catalonia, the CIMCAT, which is one of the most famous centers of MS all over the world, in the University of the Hospital Vall d'Hebron in Barcelona, Spain. And she will be talking to us tonight about highlights in the research on progressive multiple sclerosis. Dear friend, dear colleague, the stage is yours.
Thank you. Thank you so much, Professor Zakaria, for this warm introduction. Also to Professor Hani, it is my deep pleasure to be here with you today. And even if this is on a virtual mode, it is my great pleasure. And also to share the podium with distinguished speakers such as Professor Absenta. So I'm going to try to highlight some of the important challenges that we face when we are dealing with such a hot topic such as progressive MS. These are my disclosures, and this is going to be a little bit the outline of my presentation. We are going to see that probably natural history of this disease is changing nowadays. We are going to also see that probably the phenotypes are evolving, and this is also an important area of research. We are going to see that progression probably starts much earlier than what we used to consider, and that we have a problem in the way we measure progression nowadays. Also, we are going to see the difficulties that we have for differentiating what is happening because of progression and what is a consequence of the aging process. I would like also to highlight the important concept of brain reserve and some of the key issues related to treatment of progression. Looking at the first part of my presentation, this is a long-lasting disease, and our patients have to live with MS for more than 40 or 50 years. If we look to the classical natural history studies, what they say is that approximately half of our patients will need a cane after 20 to 25 years. But in fact, things maybe are changing. If we look to the CIS cohort followed in Queen Square, and we look at patients classified according to their baseline MRI, we can see that half of their patients, after 15 years, they were an EDSS of 6. In our cohort of CIS patients in Barcelona, we try to classify our patients in the same way. And we realized that, in fact, after 15 years, only 9% of our patients were, in fact, needing a cane. So we were seeing that we had the clearly lower rates of disability compared to the London cohort. And as it has been nicely summarized in this paper, MS seems to be becoming a milder disease. And probably this is due to the fact that in the past 25 years, we have been able to reduce by almost 70% the time from CIS to diagnosis. And even more impressive, we have been able to reduce by 85% the mean time from CIS to treatment onset. And probably because of these two changes, and probably because of many other hidden factors, we are seeing that for a given age, our patients have much better outcomes in recent years compared to, for example, the Poser criteria era. So for a given age, our patients are clearly doing better. Also, another important thing to consider is that the phenotypes are also evolving and probably will even evolve more in the near future. We used to classify progressive MS into patients who were primary progressive or secondary progressive. But in the 2013 classification, these two categories were merged into a progressive disease categories in which the highlight was then put in whether we are in a progressive active disease or in a progressive not active disease. And activity means patients that are progressive and have clinical relapses, and or MRI activity, which means new T2 or GAD lesions. And why is that activity is important? Because activity means inflammation. And of course, inflammation is something that we know how to target it. And inflammation is related to age and disease duration. I would like to share with you some data related to when progression starts. And here, many changes are occurring. We were used to say that there was a preclinical phase in this disease. Then we had the relapsing remitting phase, and then the secondary progressive phase of the disease. But probably this progression starts much earlier. And we are going to see some of the data that are behind this new concept. When we look at neurofilaments, and the neurofilaments can be probably a surrogate of neurodegeneration and also of inflammation. And this is a study looking at patients that are pre-symptomatic. So if we look to the levels of neurofilaments in patients that are completely asymptomatic, but in which we were able to have blood from these patients years before they developed the disease, we see that in presymptomatic patients already there is an increase in neurofilaments. And that if we follow these patients that are asymptomatic, there is an increase in the levels of neurofilaments, probably telling us that something is already happening years before this disease starts with the first attack. Also, this is interesting data coming from the OPERA trial. You know very well that the OPERA trial was a very typical relapsing remitting population. And looking at the proportion of patients that have presented with confirmed disability accumulation, and this was around 1/3 in the OPERA population. And this is looking at how many of this proportion of patients that are worsening, this is due to an incomplete recovery from a relapse, and in which proportion this is due to a progression that occurs independent of relapse activity. And to our surprise, in this very relapsing remitting population, in fact, the great proportion of accumulation of disability came because of progression independent of relapse activity, and as very small proportion because of incomplete recovery from a relapse. And this is telling us that silent progression is already present in a population that is considered relapsing remitting. And we also presented this year at ECTRIMS by Professor Tur from our center that this phenomenon called PIRA is already present in a proportion of patients in a CIS cohort. So 10% of our patients already present with PIRA at 5 years after a CIS, telling us again that probably this is an early phenomenon. Why then we do not detect progression? And this is probably due, at least in part, by the fact that we are still measuring progression with EDSS. And we all know that EDSS is a very insensitive measure, especially during the first part of this scale. So with patients that have mild disability, there are many symptoms that occur that probably are not captured by the EDSS. And probably from the clinical point of view, we have to move to more sensitive tools to try to capture this early phenomenon of silent progression. And in this sense, probably digital or e-health can help us to detect these milder symptoms. And in this sense, probably step count, which is something that we can all have in our telephones and in very simple devices, there are very nice studies showing nice correlations between the number of steps that we do daily with EDSS. So maybe this is a tool that we can explore to see if we can detect early changes in progression during the early phases of the disease. But of course, progression has to be targeted and has to be monitored, not only clinically, but also with MRI. And I'm not going to go into deep in this area because Professor Absinta is going to much more properly talk about this. We know that imaging is very helpful to detect focal inflammation, and focal inflammation is related to relapses and to inflammation. But we are learning also, thanks to work, for example, done by Professor Absinta, that maybe with MRI, we can also target this chronic active inflammation that is much more characteristic of progression. And this is, in fact, already being studied in, for example, some of the more recent clinical trials, in which we are able to also look at this chronic inflammation. Of course, we have other tools to try to monitor progression, such as brain volume loss or spinal cord volume loss. And we know that this is very useful at the group level, but much more difficult to utilize at the individual level. Also, biomarkers such as neurofilaments can be of help, but neurofilaments are also very much, in a certain way, contaminated by inflammation. So they are not probably a measure of neurodegeneration alone, but of the combination of inflammation plus neurodegeneration. Another important area of research in terms of how to improve in progressive MS patients is that when we look at the pathophysiology of progression, we learn that when progression starts, there is a much more chronic inflammation, there is axonal degeneration, but also we are learning about the importance of microglia activation, of mitochondrial injury with difficulty and loss of energy, and with the accumulation of oxidative products and glutamate dysregulation. But when we look to what happens with aging, in fact, we see very similar phenomena. When we look at what happens with aging, we also look at microglia activation. We also have loss of neuronal processes. We also have meningeal follicles, and also have this chronic inflammatory state. So it is complicated to disentangle which are the processes that are happening are due to the to the fault of progression or as a consequence of age. And this is also happening with immunity. You know that aging immunosenescence also occurring. And this is responsible also for many of the things that are related to progression and also to infections. I'd like now to comment on the importance of the concept of brain reserve. This is also an important area of investigation. You know that our brain has the capacity to compensate and the capacity to repair. And this is because of the brain reserve. This brain reserve is very nicely shown in this cartoon as the water that we have in a pool. The water is the reflection of this reserve capacity. Unfortunately, we all lose reserve. We all lose water because of our aging process. But the problem is that with MS, you also lose capacity of reserve because of inflammatory activity. Every time you have a relapse, every time you have an UT2, you also lose water. You also lose this reserve capacity. And the problem is that when you have this brain reserve, then you are able to compensate and to recover. But it reaches a point in which you don't have any more brain reserve and you enter into the trouble zone, which is probably the moment in which now we tell our patients, well, now you are in a secondary progressive phase of the disease. This is the moment in which they have lost this capacity to repair. And this is also true for cognition. So we have a brain reserve that is a cognitive reserve. The problem is also how to measure this brain reserve. And there are some initiatives trying to look, for example, to the intracranial volume as a surrogate of brain reserve. Looking at the treatment properly of progression, probably the most important treatment of progression is in fact early treatment. We have very nice data from different registries showing how if we treat this disease from the very beginning of the disease, we are clearly delaying the onset of progression. And this has also very nicely been shown in this recent paper from the big MS data, in which we have a fantastic number of patients followed with for almost 13 years, and in which looking at very different outcomes. In all of them, early treatment is clearly associated with a delay in many of these outcomes. So early treatment is the most important factor to delay progression. Of course, once we are in the progressive phase of the disease, we have also certain treatments that have shown efficacy. And in this sense, we have recently some treatments that have been approved for their use during the progressive phase of the disease. Even a very moderate efficacy drug, such as interferon, already showed that when there was still some inflammation in the progressive phase, interferon was useful. Looking at a very much more modern drug, we have siponimod, that is the first drug approved for secondary progressive MS. And you see that the overall efficacy is around a decrease in 21% in the proportion of patients that having 3 months confirmed disability progression. But if we look to the population with active secondary progressive MS, the effect is much larger, around 31%. This is also true for cognition. This drug has also decreased the proportion of cognitive impairment, but again, you can see that the effect is much larger if we look to active secondary progressive MS. And this is also true not only for secondary progressive MS, but looking at a population with primary progressive MS treated with ocrelizumab, the effect was around 24% for the full population. But again, the effect is much larger, around 45% decrease in the risk of confirmed disability progression if we are considering the population with active primary progressive. When we look at the effect of these anti-inflammatory drugs in the other counterpart, those that are non-active, then the results are much controversial. In the siponimod trial, looking at the non-active secondary progressive MS, here the effect was more modest. And the same was true for those patients with a non-active disease in patients with a primary progressive MS treated here with ocrelizumab. So probably in the future, trials should differentiate progression with activity with progression with non-activity to really disentangle which of the effect of these drugs is due properly to the anti-inflammatory effect, or whether if there is also a further effect that is beyond inflammation. Another fact that we think is important to take into consideration for future trials is the therapeutic lag. And here I would like to share with you the experience that we had years ago treating patients with progressive MS. This is a trial that we performed many years ago in Barcelona with a population with patients treated with interferon or placebo, and these were patients with progressive MS. After 2 years, we did not see any difference in those patients treated with interferon and those patients treated with placebo. But we decided to follow those patients for 3 more years. And to our surprise, those patients that were treated with placebo, they were doing they were progressing in the same rate. However, those that had been treated with interferon, they seemed to be progressing more slowly. But to our surprise, this happened later than 2 years after. Of course, it is clear that we need drugs that are beyond anti-inflammatory drugs and that new mechanisms of action are needed. And in this sense, we have drugs such as simvastatin that showed a very nice effect in atrophy compared to placebo in a small phase 2 trial. And we are awaiting the results of the phase 3 trial, which could confirm these results. Also, another interesting drug is ibudilast, who also showed a clear effect in the rate of atrophy when compared to placebo. Interestingly, ibudilast did not have any effect on inflammation, so it looks as a very possible add-on therapy for treating progression. Another interesting drug could be clemastine, who showed some capacity to repair measured by visual evoked potential in patients with optic neuritis, but a small trial for the moment. And also lipoic acid with an antioxidative drug, which also demonstrated some effect in a small trial in terms of atrophy. Also, this study was presented a few days ago in the ECTRIMS, in which it is a small trial, phase 2, looking at the effect of bone marrow cells, derived mesenchymal stem cells that were introduced intrathecally, and with interesting results in terms of biomarkers. But again, a very small study with 20 subjects. So another important aspect that I would like to mention is that when we are targeting the progressive population, in fact, we are targeting a population that is aging. And more, our patients live longer, and the age of the general population is also getting older. And the problem is that our clinical trials only include patients that are around 50 to 55 years. And in fact, the target population is patients that are much older. So we need probably to include those older patients also to our clinical trials, because we also know that for the same drug, the effect seems to be clearly less effective, these anti-inflammatory drugs, in the aging populations. And also very important, when we are dealing with progressive MS, long-term safety data are needed. In this sense, in the ECTRIMS also, we had reassuring data concerning long-term data use of ocrelizumab in terms of infections, and also reassuring data related to malignancy in patients treated for 8 years with ocrelizumab. However, still, data coming from real-world data are very important. And for example, from the Swedish cohort with registries, they showed us that the risk of infections in real life is increased, for example, for patients treated with fingolimod or with rituximab. And also interesting data coming from the COVID international data sharing, in which we confirm that for certain drugs, such as anti-CD20, in the COVID infection, we are seeing the increased rate of several concerning outcomes in relation to COVID infection. So definitely, this is an international effort. And here I would like to highlight the importance of the Progressive MSI Alliance, which mission is to target this specific progressive problem. And also, I would like to highlight several other important networks that are also trying to figure out how we can address this progressive problem. Finally, I would like to highlight the importance of addressing this treatment of progression in a more holistic way. We have to remember that exercise has clearly an impact in the concept of brain reserve. If our patients do exercise, they increase the brain reserve. And also, if we are also targeting some environmental factors, such as vitamin D, such as body mass index, such as diet, and such as avoiding smoking above all, we are also targeting the increase in reserve. And also, don't forget about rehabilitation and about the treatment also of comorbidities. So this is my final slide, that we have to consider this is in a holistic way. We have to treat our patients to prevent inflammation. This is something we need to know, and we need how to do it. We need to also contemplate that our patients need to do a healthy lifestyle. They need to prevent comorbidities. Also, they need to maximize their resources with rehabilitation. And with this, I would like to conclude that MS natural history is changing in the treated area, that MS phenotypes are evolving, and that probably progression starts much earlier in the disease course. Aging is key also to understand progression. Progression probably starts early, but only becomes visible when reserve fails. Remember that the best treatment for progressive is early treatment, and that fortunately we have first drugs approved specifically for progressive MS, but they have mainly an anti-inflammatory effect. Remember that the effect may be larger because of this therapeutic lack, and that we are still of a need of a neuroprotective agents. But don't forget about other strategies, including healthy lifestyle and rehabilitation, who can be crucial to maintain brain reserve and for maximizing the use of our resources. And with that, I would like to thank you all for your attendance, and a great salutation from Barcelona. Thank you.
Thank you very much, Professor Mar, for this presentation. I guess it raised a lot of questions. it's a very hot topic today. And we'll move now. I will postpone the Q&A at the end of the session. And then we will move to Professor Dr. Martina Absenta. I guess this is the first time to invite Professor Martina. She is a well-known figure in the field of MRI and biomarkers in neuroinflammation, especially in multiple sclerosis and neurodegenerative disorders. Professor Martina, she's a neurologist in Johns Hopkins with PhD degree in molecular medicine. And she has, as I just mentioned, a great work with the ultra-high field 7 Tesla MRI neuropathology correlation in neuro inflammatory and neurodegenerative diseases, especially multiple sclerosis and other disorders. This is a very hot topic today, as we just started with Professor Mar. I guess Professor Martina will cover the perspective of the biomarkers, especially on the MS side. Dear Professor Martina.
Thank you very much for the invitation. I'm sorry for the voice. I got a cold yesterday, so I'm very sorry about that, but I'll try to do my best to speak out loud. Let me know if I have to repeat something. So today, thank you so much for the invitation, and thank you to Professor Tintoret for the beautiful talk and the nice overview about the progression in MS. So our topic here, we are speaking about the chronic active MS lesions. And I like to introduce my talk showing you a time-lapse, MRI time-lapse, in which I collected MRIs over 24 years of the disease. So we see over time many appearings area here, enhancing after contrast injection. So these are the inflamed, new active MS lesions, inflamed lesions. Over time, you can appreciate, I can show you again the video, you can appreciate also the enlargement of the ventricles here and also enlargement of the size, suggesting brain atrophy. So this is a pathology in which it's heterogeneous, in which inflammation and neurodegeneration coexist, as Professor Tintoret mentioned before. And I will show you again. It's interesting that over time, the lesions appear to be, now you've seen a bit, more destructive, I'll show you here, and enlarging over time, like in this case here. You can see they are becoming more and more dark over time and even enlarging. So today we will speak about exactly this type of lesion. So this disease is heterogeneous, not only from a pathological point of view, but also from a clinical point of view. And this is a real case. So this patient was running at age 30 and was in a wheelchair, unfortunately, at age 54. So about 15% of our patients still are reaching the progressive phase of the disease. And we have really efficient drugs today, able to limit the inflammation and to suppress the peripheral immune attack, so the new lesions happening in our brain. However, we are now thinking about our central nervous system is responding to this peripheral immune attack. So, and in this case, we are thinking about the modulation of this response. So we are thinking about the modulation of the glial cell response. And I'm introducing here microglia and astrocytes. So these are a bit of paradigm shift in comparison to the past. So and we think that a great way to look for this CNS response is to look actually at the fate of the MS lesions. And looking back at the pathology, we know that after the initial inflammatory phase subsides, so the lesion onset, the fate of MS lesions can differ a lot. We have the chronic inactive lesions, so they are fully demyelinated. These are hemispheric coronal staining of coronal human hemispheres. With LFP PAS, we can see the area of demyelination. Myelin is blue, the cortex is pink, and the demyelination is pink as well. And we have here iron staining. So you can see there are the chronic inactive, so fully demyelinated without many inflammatory cells, actually burnout probably. On the other end of the spectrum, we have the remyelinated lesions. So these are lesions in which repair happens, actually. We have thin myelin layers trying to cover the naked axons. And here we can see a pale blue staining here. But the most interesting to me, so I've been working on this in the last 10 years, actually, are the chronic active. So in pathology, they are fully demyelinated, you can see here, but they have this interesting hedge full of this dense inflammatory infiltrate composed mainly by microglia and macrophages. So here CD68 staining, and also these inflammatory cells have iron inside. So this will be very important for the imaging biomarker. And on pathology, two big pathological studies show that the chronic active MS lesions, so these plaques here, are about 30% of the plaques autopsy, and a little bit more frequent in progressive MS cases. So until recently, was not possible to distinguish this type of lesions in vivo. Game changer was the use of the 7 Tesla first and these susceptibility-based MRI images, in which we can now start to see this dark edge here. And because these susceptibility-based imaging are sensitive to the paramagnetic substances, they can actually see exactly this kind of macroscopic pathology. So the ion here within the microglial cells can be now seen in vivo here with the MRI. So I said the first beautiful images came from 7 Tesla scanners, but now we work on the protocols and we are able to see those also at 3 Tesla. I have seen one study also where they have been seen also 1.5 Tesla. So it's becoming more and more approachable from a clinical perspective. So in the last 10 years, several MRI pathological studies try to validate that at least a subset of these rim lesions are actually chronic active lesions. And this has been shown also using a correlation study also with the PET, the TSPO PET, so for the macroglia and astrocytes activation. Interestingly, the presence of this type of outcome, so I mean chronic active MS lesion, is very specific of the human disease and so far not well modeled in animal models. So we don't have a mice model for chronic, so they are not harboring this kind of lesions, and nor the marmoset. So I have been working a lot with the marmoset EAE at the NIH, and we never seen one chronic active lesion in the marmoset. So far we can only work on the human subjects. So this is very, very important. So even to better understand immunological mechanisms or to test treatments. So far it's not possible to test in animals. So when we look at larger cohorts, using mostly 3 Tesla and 7 Tesla scanners here, these chronic active lesions seen as paramagnetic rim lesions are frequent and specific of MS. So this is interesting. We did these studies in which we found that very, very rarely we could see this biomarker in MS mimics. In particular, we found in some Sussex disease, we saw some of the corpus callosum lesion dark edge on the T2 star images, but other than that, not much. So it's pretty specific, so might be useful for a diagnostic purpose, especially in association with the central vein sign. Here we estimated that the specificity will be up to 99% using both biomarkers. But in our MS patients, about 50% of them, they have at least one chronic active lesion, about a little bit more in the progressive MS cases, so about 60%. But the very important thing is that those relapsing remitting cases with several chronic active lesions, so we here in this cohort, we estimated 4 from a statistical point of view, they had a higher risk to progress at a younger age and shorter disease duration. So people having more than 4 chronic active lesions had higher disability scores and lower cognitive performances. So this suggests us that, first of all, this seems to be a prognostic biomarker, and that the chronic inflammation and the chronic active lesion might be one of the contributors to the disability accumulation and progression in MS, together with others. So there are other important prognostic, of course, contributors for disability and disease accumulation, such as the spinal cord pathology or the cortical pathology, as shown in the past. Here we are suggesting that also the chronic active lesions are one of these contributors. So, but why having, a bunch of chronic active lesions is associated with this worse prognosis and progression? So we realized we thought about three main reasons. First of all, chronic active lesions or lesions with this rim do not repair and do not remyelinate. And we show this point in this study, and we show that having early on, so after the lesion onset, this persistent rim, you can see here, was associated to higher lesion volume at year 1 in comparison to those without this rim, and worsening of the T1 lesion values over time. So suggesting that these lesions at year 1, they were bigger and more destructive in comparison to those without rim. So the presence of the rim at month 3 was able to clearly classify the long-term fate of these lesions. So the chance to try at least to remyelinate, though, and on the other side, in those lesions with a persistent rim, no chance to remyelinate. So this is a pretty important point, because the persistence of this chronic inflammation is a major obstacle for remyelination. The second reason for the association with the disability is that these chronic active lesions are, at least a subset of them, are expanding over time. So there is this edge, is an inflammatory edge, is a smoldering, demyelinating edge affecting the surrounding normal tissue. And here in this MRI pathological study, we follow this patient in vivo, and at death, he donated his brain for research. And here you can see his scan at 7 Tesla. You can see the majority of his lesions show this biomarker, this rim. And I selected 10 of those for histological assessment. All of these lesions were growing in serial MRI scan in vivo over time. And here an example, you can see at age 52, it seems there are 3 lesions, but then over time they are becoming bigger and becoming confluent. And at death, we got the brain, we did the MRI, you can see here the rim, these are the central veins, this is the corresponding pathological piece with the demyelination, at the edge, the ongoing demyelination. So you see there are fragments of myelin, debris of myelin here. And again, this dense inflammatory infiltrate of microglia, macrophages, and ion, again, that is likely the reason why we are able to see these biomarkers. So these lesions are very destructive. They do not remyelinate. The majority of them probably, they tend to enlarge over time, although let's say that overall, since there is atrophy, this enlargement cannot be seen in all the lesions, but let's say some of them clearly enlarge over time, they become confluent, like in this case. The third reason is that there is at this edge ongoing acute axonal injury. So, and this is something we can see here in pathology with this axonal end bulb, these ovoids of APP. So when an axon is transected, there is the formation of this axonal end bulb here. And these figures are not seen in the other pathological areas, like in the chronic inactive lesions. Here you can see the inflammation. So a way to look in vivo for axonal injury is to look at the neurofilament release in the CSF and the blood. So we did an association study to prove in vivo that the presence of these chronic active lesions were associated in vivo to elevation of serum neurofilaments chain. And so we enroll a cohort of non-active MS cases This because neurofilaments can elevate pretty well with active lesions, gadolinium-enhancing lesions. Here we wanted to check those serum neurofilament light chain in non-active cases for at least 6 months. And here you can see that having this type of lesions were associated with the increase of the neurofilament light chain much more than other factors known to increase serum neurofilament light chain. So, of course, these measures were corrected for age because one of the most important factors elevating serum neurofilament light chain is age, of course. So here we couldn't disentangle, as Professor Tintoret said, about neurodegeneration per se versus inflammation. Here we wanted to prove that having these chronic active lesions was actually very bad also for ongoing and acute axonal injury happening at these lesion edges. And we know that axonal injuries is strictly associated with disability. At this point, we ask a question about how is this rim, this paramagnetic rim, very stable? What's happening in very long follow-ups? So within 1 or 2 years, at least in our cohort, this feature was very stable, so we couldn't see differences. But now, looking at very long period of times, like we have now 9 years of follow-up, for example, we could see that some of these lesions, of these rims, are fading over time. And so this means that these rim lesions are actually a dynamic MRI biomarker, so are sensitive to the underlying pathological substrate, in this case, these microglia, activity microglia at the edge. And here, 2 examples. So this one is a very persistent one. This is a leukocortical lesion. You can see this dark edge here. So very persistent from age 33 to age 38. But here you can see a disappearing rim. So we can see here, but then fading over time. So this is quite important because it means that we can see changes occurring at this edge. So the lesion was not disappearing. So we could still see these lesions on the flare, on the T1 images, but the rim, this dark edge here, was not visible anymore. And we estimated that the median survival time for this dark edge was about 7 years in this cohort. This is a study done at 7 Tesla. So at this point, since having this chronic active lesion seems to be bad for patients because it's associated with early disability, our goal is now to try to accelerate this inflammation resolution in these chronic active MS lesions. And what we have, so we have a dynamic biomarker. See, in the last 10 years, several studies, including our study, but also from several other groups, try to validate the biomarker and that these paramagnetic rim lesions are actually chronic active MS lesions. Recently, we understood the clinical role for progression. And so what we want to do is to design clinical trials. The clinical trials we want to design need to be newly designed because here we are using a biomarker never used before. So here I try to think about how to possibly design this clinical trial and to do a power analysis based on the 7 Tesla data we acquired so far. So if we think about to use a binary outcome, so stable rim lesions versus fading or even disappeared rim lesion, like in this case. So at baseline and follow-up, the same lesion will be compared at baseline versus follow-up. If we want to test the hypothesis that our drug for 1 year, given for 1 year, will increase by 10% the proportion of the fading disappearing, so making this rim going away, we only need 16 people per arm and 56 lesions to prove that with a power of 80% and 0.05. This is quite interesting because we can think about designing small proof of concept clinical trials with several potential drugs to screen to then move forward for bigger trials. And these numbers and this power is related to the fact that in a short period of time, so 1-2 years, these rims are very stable. So any drug able to reduce this dark edge in 1 year will have a sure effect, because we, like in a natural history, we never see a rim going away within 1 year, but with several years. So we are here. As I said, we don't have really animal models to better study the pathophysiology of these lesions. So to better understand the neurological mechanisms, potentially find therapeutic new targets, and eventually to do a drug prediction, we recently used human single nucleus RNA-seq using and sampling these edges. I will talk about in the next slide about this study, to try to better understand what's happening at the edges in the human tissue. And on the other hand, thanks to Progressive MS Alliance grant, we are genotyping our patient and classifying them according to the number of these chronic active lesions, to again identifying genetic predictors of potentially progression and chronic inflammation. Again, all this work is to look for new therapeutic targets and potentially drug prediction. So in the next few minutes, I will try to tell you more about the biological insights we got profiling the human MS plaques. And here I'm looking only to white matter lesions, so this is not related to cortical lesions. So what we did, we got frozen brain tissue from autopsy cases of MS, and we used this sampling strategy. It was MRI informed, so we sample the edges of these lesions, the core of the lesion, the periplaque. We compare 5 with these different sampling 5 chronic active MS lesions versus 5 chronic inactive. And we compare against the control white matter from non-neurological people. The age range was kind of narrow, and we wanted to avoid older cases because we didn't want the aging effect of the glial population, and we extract the nuclei for the next genomic. So I don't know if you are aware of the single cell RNA-seq technique, but it's a quite novel technique. It's able to provide the full transcriptome profile for each cell, in this case, for each nucleus of our tissue. And nuclei with similar transcriptome profile are, after the bioinformatician analysis, are putting together in these maps. So here you can see there are dots. These dots, each of these dots is a nucleus with a full transcriptome profile. So all the RNA produced by these nuclei has been identified and sequenced with this technique. And now, put it together, you can see that the lymphocytes are staying all together. The immune cells are staying, close by in these maps all together. The astrocytes, the oligodendrocytes, the oligodendrocyte precursor cells here, the vascular cells. And I had only few neurons, because the sampling was quite precise and involved mostly exclusively the white matter. So I didn't want to look at the cortex here. So we then look at the subclustering analysis. So I did an analysis for the immune cells, for the oligodendrocytes, UPC astrocytes. And this subclustering analysis showed pathological stage, location-specific population diversity in MS. So if we look at the immune cells, what you can see here, the chronic active edge, is an expanded population of microglia, activity microglia with a TREM2 APOE signature. This is the signature we know from also the Alzheimer field, for example. we have expanded population of T cell and plasmablast and still some peripheral monocytes. What is remarkable from the oligodendrocytes analysis is that we have tons of stressed oligodendrocytes in MS tissue only and not in the normal tissue from non-neurological controls. And these stressed oligodendrocytes, the definition of this is that they have upregulation of the unfolding protein response and mitochondrial damage. Also, move this one here, yes. Also for the OPCs, so the oligodendrocyte precursor cells, what we found at the edge was kind of interesting. So again, stressed oligodendrocyte OPCs, but also this population of immune-like OPCs. So these are novel described cell type, and these OPCs are starting to present antigen, so contributing again to the inflammatory process, and they seem to be even cytotoxic upon interferon gamma stimulation. So they, instead of being, the cells that are able to repair and to remyelinate, here in this inflammatory environment, in this inflammatory context, they are actually participating in the inflammatory response, presenting antigen, being cytotoxic. While the pre-myelinating oligodendrocytes are equally distributed along the different pathological stages, so control, periplaque, chronic active edge, chronic inactive edge, and the core of the lesion. Also, the astrocytes, quite interesting, expanding population of reactive and inflammatory astrocytes. Some of them, here you can see the markers, some of them with these A1 markers. So these have been described a few years ago by Lidolo and are part of these astrocytes called toxic, because again, they are able to produce molecular substances that are toxic for the CNS. Actually, looking more carefully to the activated microglia population, we found that this population, this TREM2 APOE population, was actually split in two different clusters. The first cluster we called FOMI because of the upregulation of the phagocytosis and lipid processing machinery. You can see here the genes. And the other one, we could see upregulation of the ferritin genes, ferritin light chain, ferritin heavy chain here. So we think that these are those we call iron, because we think are those we were seeing in the histological stainings I showed you before, and the reason why we are able to see these lesions in vivo with our biomarker. So these cells are particularly inflammatory. They have upregulation of the ribosomal genes, so are very active cells. Again, they are presenting antigens, so these are the HLA class 2 and all the machinery for the HLA class 2, and they are also overexpressing complement C1q genes. So to prove that this was kind of true, with several things, comparing this data set with previously published data set to find if there was these two populations. And the other way was to look in tissue, because this is based on the transcripts, so the gene transcripts. So the other way is to look to proteins. And again, we did a multiplex immunostaining, so with different round of staining. So it was quite kind of a laborious work here, but here what we got, several layers with several stainings, and we can clearly see that there are microglial cells with a lot of ferritin genes, while there are microglial cells without ferritin protein, and they are localized at the edge and actually close by. So meaning that there are mixed population of microglia cells more involved in the myelin demyelination and cleaning, and together with these cells that are particularly inflammatory. Again, another important population is the one of the astrocytes, very inflamed astrocytes. You can see here vimentin staining, very, very upregulated the vimentin here, and without ferritin. So the cells that we think are associated with our imaging biomarker, we think are the microglia cells. So to better understand now how the different populations at the lesion edge were speaking one with another, we computed the glial interactome. So we tried to understand ligand receptor interaction, and this is the map we got. So there are a few interesting things here, I think, to get. First of all, the lymphocytes, so the plasmablast and the T cells, are important in the network, and they are at the edges of the network. So it seems that few lymphocytes are actually able to activate a cascade of glial reaction and expansion, you can see here. But the most important populations in this network are actually the activating microglia populations and the inflammatory astrocytes. And it seems that they are hubs of this network because they have the majority of the connection with all the other populations. So if we think about how to disconnect this network, probably taking down this population might be something to think about. Now you can start to look, what exactly is happening in this crosstalk. And for example, this activity microglia with ion is expressing this Fc receptor for the immunoglobulin, and this Fc receptor has been shown to be able to activate directly microglia in presence of IgGs. So this is a nice connection to look at. Then we look for how this activity microglia was stimulated by the inflammatory environment. And this is a completely different analysis using NISHNet is again to model cell-to-cell interaction. And you can see that the majority of the ligands affecting the target microglia genes are from the T cells, again, the plasmablast, and by the microglia, activity microglia itself in a paracrine way. As I said, the most interesting connections are between the activity microglia and the astrocytes. Here we tested again our data set in another way using the co-expression network. So gene modules, you can see here how gene modules in the microglia and in astrocytes co-express and co-regulate at the chronic active edge. And we found nice correlations, so suggesting that actually they are really interacting each other. And when there is activity microglia, there are also these inflammatory astrocytes. And we saw nice in vivo tissue interaction, like in this case, we found nice activated microglia and astrocytes, sometimes even close by in a spatial interaction in tissue. Among the highly differentially expressed genes, we found the early complement genes. And this was I tried to identify and verify these in tissue again with proteins and with staining. So I stained for C1q, and C1q was highly expressed here at the chronic active edge in comparison to the periplaque or the core of the lesion. Here, extending the analysis also to the cortex, for example. And you can see here C1q staining and also C3 staining. C3 has been studied a lot because it's important for synaptic pruning, so contributing to remove, so the microglia is able to remove the non-functioning synapses, so to prune them thanks to these early complement genes. So in the central nervous system, the complement system, so the early complement genes C1q and C3, seem to have a different role, not only related to the complement cascade that we all know, study in the past, and they are very important to fight pathogens, but they seem to have additional functions. For example, C3 in the synaptic pruning, and now we think that C1q is important in the activation of the microglia and the interaction as a mediator in the interaction between the microglia and the astrocytes. So this is, we focused on this particular target and mediator, And we did a couple of functional studies implementing animals. But first of all, we did another thing. So to understand whether these early complement genes were somehow related with this impaired inflammation resolution, we genotyped 1,200 MS patients. And some of them had also the MRI, in which we look for these chronic active MS lesions. And then we look for these gene variants previously identified in the science paper. There is this science paper with this international genomic study looking for risk genes associated with disease. So here we took exactly these gene variants and we correlate them with the number of the RIMs. And you can see that the cumulative incidence of these risk variants associated with the complement genes was associated with the higher number of chronic active lesions. Of course, this is a bit underpowered because we need a little bit more subjects to prove that. So for this reason, we applied to the Progressive MS Alliance. We got this grant to extend this genotyping MRI, so this GWAS MRI study looking for genetic predictors of the chronic inflammation and chronic active lesions, because we think that having some of these variants, so variants associated with the early complement genes, might be related to this impair in the inflammation resolution happening when the lesion forms. So again, coming back to the first slide, how the brain responds to the inflammatory attack from the periphery. So this might be a reason for why these lesions form, one of the reasons. To, as I said, to prove that C1q was important for microglia activation, we did a couple of animal studies. In this case, we used a microglia C1q conditional knockout. So C1q was ablated only in the microglia cells and we induced EAE. The important thing is to look at here, this area here. So in the conditional knockout for C1q, when you are doing DIE, we don't see anymore the activation of the microglia. CLEC7A is a DAM marker, so disease-associated microglia marker. So it's a marker really important, described also again in the Alzheimer's field, associated with the activation of the microglia. And also the IBA1 cell, so the microglia cell staying with IBA1 show morphologies that are more ramified. Here you can see the graphs, more ramified and not amoeboid as in the normal control EIE. So genetically removing C1q was prevents the microglia activation in this early EIE model. To further prove this relationship, we used a C1q blocking antibody. Again, we induced the EIE and we start to administer the C1q blocking antibody. What we look at this point, we look at later time point in the chronic EIE. And what we found here was the reduction of the microglia with iron. So again, this was really associated with our human, if you want, finding of these microglia with this iron accumulation. So using this C1q blocking antibody was reducing the activation of the microglia, especially the one with iron. Unfortunately, the EIE scores didn't change at all. But again, this might be related to the animal model that is not associated with the formation of this chronic inflammation, and mostly because in this type of model, the spinal cord injury, you can see it's happening pretty early in the course of disease, is actually then driving the disability. This is not changing over time. So this is not a model for progressive MS. Of course, you can see because it's reaching the EIE score of 3 and they remain stable. So here we didn't want to modify the EIE score, but looking exactly what was happening to the microglia population. So this is my last slide with the take-home messages. So a subset of chronic active MS lesion can be seen in vivo using these susceptibility-based MRI techniques as rim lesions, so lesions with this paramagnetic rim. This is due to the accumulation of ion-laden microglia. Mostly, we think about the reason. Now we can see these lesions 7 Tesla, 3 Tesla, and there are a few studies also trying to see them at 1.5 Tesla, so that's great. The rim persistence marks chronic inflammation, failure of early lesion repair, tendency for this slow expansion over time. So these are sites of low burning inflammatory demyelination. You have to think about that. You have your patients, you track, you monitor them with gadolinium enhancing lesion or new lesion, but the previous lesion, this chronic lesion, some of them are hotspot and you are not able to see them without this technique. So you don't know that they might have this type of lesions. Patients having several chronic active lesions reach disability early. We show that with cross-sectional studies mostly, and with the concomitant axonopathology, with the elevation of serum neurofilaments light chain. It's very, very important now to design longitudinal cohort study to fully prove that having in your relapsing phase several chronic active lesions is a prognostic factor and driving the disability later on. We used this MRI-informed human single-nucleus RNA-seq to try to understand what was happening at the edge from a biological point of view and to potentially identify new therapeutic targets. Here we focused on C1q as critical mediator for microglia activation, but there are several others, and the dataset is public and can be searched by other researchers, and I hope several other people will look for in these datasets for other targets. And finally, our biomarker is dynamic, so it's very sensitive to what's happening at the lesion edge. So when the microglia is going away, also the rim is going away, and we want to use as a potential outcome measure for newly designed clinical trials, trying to accelerate this perilesional inflammation resolution. I would like to thank all the people I've been working on in the last 20 years probably, and the founding agencies, and all of you for your attention. Thank you.
Thank you, Professor Martina, for this important topic and illustrating about the complexity of the chronic active lesions. And it's obvious that things are getting more and more complicated to understand the progression. But I guess it's important, of course, to develop new therapies and targets such mechanistic or mechanisms involved in the activity of the progression. I will let Professor Magd to ask the question in the beginning, and then I will take the lead afterwards.
Thank you very much, Professor Martina. Of course, thank you very much, Professor Mary. I have just a question for each of you at the beginning, and then afterwards Dr. Hani will manage the questions of the audience, because I don't have actually access to the questions of the audience. So I will start with my dear colleague, Mary. As you were saying that the progression, when does it start? It seems to start early by the evidence of the PIRA. So don't you think that the mere existence of the PIRA is totally against the definition of secondary progressive MS?
Yes, thank you for the question. I really think that we have to shift the way we are classifying this disease, because secondary progressive only means that we are measuring this disease with an EDSS who tell us that after 500 meters, you are starting to have a restriction that we are able to measure. But these patients start many years earlier, that they stop running, they stop doing intensive workouts, etc., etc. No? So for me, this definition represents the far end of this progressive phenomenon that probably we are starting to understand that is clearly there for many years beforehand, and we need to ways to measure it. No, and of course, if we could measure it with something like these rim lesions or with biomarkers that would, and we have to probably learn from other fields such as Alzheimer's disease, in which they are going much more into the biomarkers area, and in which the clinical phenotype is only one of the results of this. But probably this is too late if we are relying on trying to target progression when progression is completely present and there's very little to do then.
Thank you very much. Professor Martina, thank you very much for this very interesting topic. As Dr. Rani was saying, things seem to be much more complicated at least for the regular physicians and clinicians, So, but I had a question that is related to a marker of progression with the MRI, maybe not the chronic active lesions, but there have been some papers about the atrophied T2 volume lesions. Do you think that this is it's a reliable marker? Because those who wrote the papers say that it's even more reliable than any other of the brain atrophy markers in the MRI.
I know what we are. Thank you for the question, and I know what we are referring at. So, in our hands, these shrinking lesions, chronic shrinking lesions, were very associated and correlating with the brain atrophy. So, we couldn't see an advantage in measuring those in comparison to measuring the brain atrophy. And what we actually saw was that when you classify these lesions based on having or not the rim, you could see this divergent volume change over time. So we, at the end, focused more, I focused mostly of my research on mostly on this chronic active lesion, because I saw that from an imaging point of view, a clinical point of view, had more association with potentially our clinical outcomes, and also from a biological point of view, had a little bit more complexity. But yeah, definitely how these lesions evolve over time, so in terms of enlarging or shrinking, is telling us about how the brain is really responding to this inflammation, to this attack from the periphery. So what I was saying in the very first slide, so it's very important to understand now how and if we can modulate these responses to the inflammation from a clinical point of view. So we should study much more about that. Thank you for the question.
Thank you very much. Thank you. Dr. Hani.
I will start with a couple of questions also. One for Professor Mar. Actually, it's related to the question raised by Professor Magd regarding this Loebling classification again. The cutoff point of 4 for EDSS. It's very limited and restricting for us, especially in defining when to shift to another medication, and especially with the coming new drugs treating second progressive MS. So you think we can, not to drop this, but at least to go for EDSS lesser than 4, because I know this might compromise the definition of progression, but as you said, progression is starting from the very, very beginning. So how we can tackle this problem?
Yeah, to me, this is, as I mentioned, a classification that is artificial, and this is a consensus that we reached. And in fact, there are many studies showing that the reliability of this classification is very dependent on the physician that is looking, and there is very little agreement when I say secondary progressive or when another person say, and this is also very much related to, for example, things such as the label, because we knew that if the patient was secondary progressive MS, we were not able to treat the patient. So there were very little patients with this label until the moment that we have a treatment that includes secondary progressive, no? So this is pretty much artificial. And I think the important thing here would be to disentangle the effect of the drugs that is clearly anti-inflammatory and the effect of the drugs that is not anti-inflammatory. And so we have a bunch of drugs that we know are very clearly anti-inflammatory, and probably this is the inclusion criteria that I would look at. Is there inflammation? Yes. So then we use anti-inflammatory drugs. Okay. And then we need to understand whether these very potent drugs or others that claim to have another type of mechanistic effect, we need to disentangle this. And we need to see if there is a real effect of any of these anti-inflammatory drugs in patients that do not have inflammation. And then there are the regulations of each country, and you need to adapt to the regulations of your country. And if this is EDSS4, then you need to adapt to the regulations of your country. But we know that the same drugs have different regulations and different, if they are reviewed by the EMA or by the FDA, so these are, to my point, and certain way artificial labels that have different reasons. But I would focus on the mechanistic approach. They are anti-inflammatory, so we use them to take out the inflammation, and we are still having a lot of doubts, which is their effect in non-inflammatory settings.
Okay, thank you. I have a question for Professor Martina. You think with this iron ring, we have to stick to the use of QSM technique, or we can use the routine susceptibility weighting image, and it can also show this iron ring. Also, there's another important marker, which is the electromeningeal enhancement with a flare. So why not, as long as these techniques can be done on 3 Tesla and even sometimes on 1.5 Tesla with good hands? So why not to do it routinely, since it's very important to know the chronic activity in the MRI?
Thank you for the question, and absolutely agree with you. So regarding the rim lesions, yes, definitely, as why with the unwrap phase or the reconstruction done on the machine, it's potentially good to visualize those lesions in a clinical setting. What we realize is that resolution is important here, because at 3 Tesla we are using submillimetric images, so 3D images with a voxel that is 0.5, 0.6. So again, in the clinical scanners, probably the SY sequence commercially put on the scanners is a little bit high with a bigger voxel, so lower resolution. So, I mean, I think that you will see something, definitely. Maybe not all of them, but it's not important. As soon as you get your cohort on your machine, I think you start to get be able to see them and to teach the radiologists to look for them. There will be a great, I think, for the future, a great important thing to do from a clinical perspective. So to try to identify at least the tip of the iceberg, so people are having this type of chronic active lesions. So QSM is mostly for quantification. And I have to say that the post-processing, so when you are processing these images to get the QSM, sometimes are applying filters that are actually sometimes smoothing or removing these edges, because they are applying these mathematical things. So sometimes it's better to look at the raw images instead of the QSM. So QSM is great for quantification, I have to say. So we are looking for qualitative assessment to the unwrap phase images. using the three-dimensional EPI sequence, providing to start phase images, but also the SY sequences are good enough if they have enough resolution to see this edge, because also from a pathological point of view, this edge is up to 500 microns. So if you have, a voxel that is much larger, you might fail to see this edge. Regarding the leptomeningeal enhancement, so yes, we look at that in the past. The fact that it was not resolving at all over years and years, it made us thinking that is a little bit less dynamic than the chronic active lesions, for example, in the parenchyma. So definitely these are two sites. So the parenchymal lesions and the meninges are two important sites for chronic inflammation. And we are actually working on to find better ways to visualize this leptomeningeal inflammation. So at this point, if I have to bet something, I will think that the chronic active lesions, so these rim lesions will be more, they will stick around longer in the field, more than leptomeningeal enhancement, the way we are doing today. So with the leakage of the gadolinium within the subarachnoid space. So because it's a little bit tricky at this point to see its dynamic behavior. So we are thinking about that. There is, of course, breaking there of the barrier, the blood meningeal barrier, but we don't know if it was like an ongoing event or a past event with fibrosis, for example. So if the barrier, the meningeal barrier, once is broken, is not able to repair. So we still see this enhancement, but is not something that is actually happening. So keeping inflammation ongoing, but something related to the past. So this is what we don't know. While for the chronic active lesions, since this rim can go away and we can see, we can track also with treatment, we are a little bit more sensitive. We are a little bit more happy about that because we think it's more sensitive to underlying pathology. So if you can do both, it's great. If I have to bet on one of the two, I will include in the clinical scanner the SY probably.
Also, another question. I know it's not directly related to the multiple sclerosis, but it's in the mimics and the same context. Regarding these, white matter changes we are seeing in the small vessel disease. Because, sometimes it's difficult to differentiate by the routine MRI whether this is due to a chronic ischemia or due to the inflammatory process and the leakage of the blood-brain barrier. You have any new techniques which can differentiate between these two aspects?
Sure. So there is also Professor Titore briefly show that the central vein sign, so the fact that the MS lesions have this central vein, so they arise around this central vein. Maybe I can do a lecture another time because there is a lot of, it's an hot topic right now because it's clearly able to differentiate an MS lesion, so an inflammatory MS lesion from other non-specific ischemic lesions associated with aging, migraine, diabetes, and also against other inflammatory vasculitis and such as Behçet disease, lupus, all this NMO, all these kind of potential mimics of MS. So this central vein sign is a kind of specific of MS. And when you measure the percentage of the perivenular lesions, so then the percentage of the lesion with the central vein, we identify a cutoff of 40-50%, clearly able to discriminate MS from everything else. So there is a lot going on in trying to, using also artificial intelligence to create automatic methods to say the percentage of the perivenular lesion in a patient directly from the scanner. So this is something we are working on with a company.
Yeah, yes, but I mean, sometimes in small vessel disease, apart from multiple sclerosis, there is two pathologies. I mean, there might be a chronic ischemia which is contributing to these white matter changes appearing as a small vessel disease, and sometimes also there is a chronic inflammatory process going on due to the leakage of the blood-brain barrier. So can you differentiate? Yeah, you got my point. It's not to differentiate between
the lesion itself. Yes, there are some techniques that are looking the gadolinium entrance in the brain from they are modeling how the gadolinium is entering the brain and identify area eventually more permeable. But these will require a lot of computational and mathematical modeling, and these are not are very experimental right now. So it will be difficult to set up in a clinical setting, I guess, at the moment.
Yeah. And in your opinion, regarding the volumetric measurements, what is the best technique we can use now? I mean, whether it's the whole brain or the specific, like the
probably whole brain will be the easiest one. There are interesting data and reliable data about the cortical volume to track the neurodegeneration over time. It's important to understand what we can use from a clinical point of view right now in the centers, and what a neurology and radiologist can use really in the clinical practice. So when I'm seeing patients in my clinic, actually, I can only look, more or less if the sulci or the ventricles are enlarged. I don't have any quantitative measures, and if there are new lesions or gadolinium-enhancing lesions. So this very limited assessment in comparison to what we can do from a research point of view. So the beauty, for example, of the chronic active lesion is that with a sequence that is not super sensitive, but is sensitive enough to show chronic active lesion like SY, maybe we can see some of them. For everything else, I think that there should be some effort by the companies selling the scanners to implement something on the scanner, or some tools that are easily using by the neurologist in the office to provide some reliable quantitative measure about volumes, brain volumes. I think it will be good enough for a clinical office at this point, at least to try.
Yeah. The question for Professor Mar, sometimes patients are put in a very efficacious drug like, ocrelizumab or Tysabri, and is kept for a long time. And probably those patients are passing into a second progressive phase, but in a subtle way. I mean, sometimes it's difficult. Probably it's those patients dropping half or one in the EDSS score, and it's difficult to get the atrophy and to get the cognition and all these things. So, I mean, with the new drug like Myzint now, you think we can, it's difficult from my point of view to shift from a very potent drug to Myzint in such patients. I mean, what are the criteria for you will stick also to the definite progression on EDSS, or you can just depend on the subtle progression despite the patient is more or less stable on a potent drug for years?
Yeah, difficult questions because we don't have data to answer this. I'm gonna give you my approach. We have shifted some patients that are, for example, on natalizumab and that are stable in terms of no relapses and no new lesions, but have some progression in the EDSS, and the patient is feeling progression. We have shifts of these patients to drugs such as anti-CD20. But my personal impression is that the benefit is very small because, again, these drugs are taking out inflammation mainly. in terms of shifting patients that are on natalizumab or on anti-CD20 but are still having some progression to a drug such as siponimod, we are just starting to use siponimod in our place. So for the moment, we are reserving this drug for those patients that are more in an active secondary progressive phase, and this is the label. A patient who is progressing but has no inflammation would not be allowed to be treated with myfen, and it wouldn't be my preferred choice to do this, even if I could, because of the label. So I would prefer to use this drug in inactive secondary progressive patients, coming more from a relapsing remitting phase. What I would clearly prefer is to be able to use this drug, such as in the American label, much earlier, because I don't understand very well the point of using it after an EDSS of 4 or whatever. This is, I think, a pity. But in our place also, we have some criteria for defining secondary progressive MS.
I don't have any more questions. Professor Magd, you have any questions or comments?
Yes, I would like to comment with Professor Mario again about the concept of secondary progression, because I'm starting to be a little bit irritated by that we're only seeing the motor progression and we're measuring at the late stage starting from EDSS-4. But we have cognitive progression, we have brain atrophy, we have a lot of features that are happening earlier, even the PIRA, the progression which is independent of the relapse activity, as you showed in your slides, they are starting in a CIS cohort. So the concept of leaving the terminology as secondary progressive, which means a late stage of motor progression, I think with all these changes that are happening, this should definitely be something different, especially if we start putting into consideration non-motor progressive items, progressive optic atrophy with the OCT, progressive brain changes with the MRIs, progressive cognitive changes starting from the RIS, even papers with RIS showing cognitive changes. So all these factors, if we put them into consideration, then the dogma of this definition of secondary progression, I think definitely it's going to change to something very different.
I couldn't agree more, Magdi, to your point. And the problem, I think, is that we are still too much attached to the clinical phenotype. And we need probably to do this jump into targeting, going more to a mechanistic phenotyping, no? And but we need better tools to monitor progression, and this is why I think the work that has been shown by Martina is so important, because if we are able to really have something that we can count, as it happened with gadolinium enhancing lesions and MUT2, they open like a fantastic area of anti-inflammatory treatment. So we need something that we can measure and that we can target for this neurodegenerative process that is independent of inflammation. And the problem with neurofilaments is that this is too much dependent on inflammation, and therefore probably it's not the better tool to target progression. But if we were able to find ways of monitoring progression and even the way that a drug could, as Martina showed, improve or decrease the number of these lesions, that would be fantastic, because I think that we are all conscious that secondary progressive is far too late, that this is an artifact because of the EDSS, etc., etc. But then when we are moving to this more mechanistic approach, we lack reliable markers. For inflammation, we have reliable markers. We have T2, we have GAD, we have reliable markers. But for progression, we have atrophy, but then at the individual level, this is very complicated. And so we need something else to do this jump into a mechanistic approach and to forget a little bit about the clinical phenotypes.
Thank you.
Also, I want to ask Professor Martina regarding this, your elegant work you presented. This C1q, you think it's a very important potential target for drugs in the future to prevent this progression of these lesions?
Thank you for the question. So I think so, because I mean, there is no drug at the moment that are under development. So it's not something we can do like tomorrow, the clinical trials, but there are under development. An interesting thing that it's been seen elevated in other neurodegenerative conditions like TBI, traumatic brain injury. So 3 days after my paper came out from Nature, another paper in Science showed the same target in TBI. Alzheimer's disease, C1q is elevated because it's strictly related to this maladaptive response of the microglia. So it's becoming something more not MS specific, but transversal, very basic mechanisms for activation of the microglia in different neurodegenerative conditions. So maybe it's a good target because there are things to use for neurodegeneration in primary neurodegenerative diseases. So we are with these very highly detailed techniques looking at the transcriptome profiles, and we show similarities with Alzheimer microglia, with microglia from LAS. So I think we need to think more outside the MS, sometimes outside the MS field, and try to find even common mechanisms that can be tested in different neurodegenerative diseases. And maybe testing in MS will show, if we're using this biomarker, we show some results that can be applied to dementias or the opposite. So I think that the fields need to speak a little bit more one with the other. And C1q is one of these cases. So is very transversal, I think.
Thank you. I guess your work needs a lot of discussion and explanation. Probably, I don't think you came to Egypt before, did you? Mm-hmm. So it's a good chance. Dr. Magd is the head of the society.
Vacation, so, no for work.
So probably we should invite you also to our congresses, at least to discuss your eminent work in a more detailed way. So if I guess there is no more questions, if any Dr. Magd or any of our great speakers would like to comment or to add.
It's a pleasure having both of you with us tonight. And we hope to repeat this again, but next time, as Dr. Hani said, face to face. We can manage everything in the Middle East, So you just give us your free time, and we will arrange a whole conference on your free time. This is one of the benefits of the Middle East, is that you don't have these rules you have in the Western society, We can do whatever we want to do as long as this is for the good benefit of everyone to listen to you and to hear you, which I'm sure that everybody will enjoy hearing what we heard today. So thank you very much.
Thank you very much.
Thank you.
Thank you.
Very
Great,
much. And,
great pleasure.
Looking to see you soon in Cairo, hopefully, inshallah.
Hopefully, inshallah.
Bye-bye.
Yes.
Bye,
Thank you.
everyone.
Bye-bye.